All right, good afternoon, folks in the room and folks joining us by Zoom. I'm Rick Hoyle, Director of the Center for the Study of Adolescent Risk and Resilience, or C-StARR. C-StARR is a CORES-only center funded by the National Institute on Drug Abuse to study innovative interdisciplinary research on the interplay of self-regulation, substance use, and social context, including the digital context. It's my pleasure to welcome you to this first talk in the C-StARR Spring 2022 Speaker Series. Especially happy to welcome back one of our own, Dr. William Copeland. After earning his PhD in clinical psychology from Vermont, Bill completed an internship and a postdoc at Duke, then joined the faculty in psychiatry and behavioral sciences in 2006, where he moved from assistant to associate to full professor before returning to the University of Vermont in 2018. From 2013 to 2017, Bill worked with Jane Costello to direct the biological methods core in the C-StARR. Bill's highly productive and well-funded research program focuses on understanding the development of emotional and behavioral health across the lifespan. His work has been funded by NIMH, NIDA, and NICHD. Findings from his work are published in JAMA, the American Journal of Public Health, PNAS, and other high-impact outlets where they've been cited close to 18,000 times. We're fortunate to have him with us and hear about his work on adolescents and young adults' involvement with cannabis. Please join me in welcoming Bill back to Duke.
Thanks much, Bill. Hi. Is there a particular spot that you'd want me to stand here? That works best. Good, good. Okay. Great. Well, it's really nice to be back down here in Durham. I was talking to my wife about this trip and she asked what I was going to be talking about. And I said, I'm going to talk about cannabis. And she said, I don't really think about you as a cannabis guy. And I think that's accurate. I'm not really that's, interested in or been interested in cannabis for a while, but it does kind of fit with a number of things I am interested in. And that is understanding what are those experiences early in life that are highly common, that have the potential to influence outcomes across the lifespan. The second thing that has gotten me interested a lot in cannabis research of late is I've started teaching first-year college students about the science of how best to cultivate their emotional wellness. And if you want to talk to first-year college students and about their wellness, you're going to end up talking a fair bit about substance use. And you kind of have to learn a little bit about this research and also how best to message this for them. And we're going to talk about that in a bit. So first of all, I don't have any conflicts of interest or financial disclosures. I have not gotten in on the marijuana industry in any way. All of my support is NIH based. So I just had a couple questions I wanted you to think about before we kind of get into the talk and while we're processing some of this data. Okay. So first of all, if you have to answer this question for yourself, do you think cannabis use is safe or low risk? Okay. How would you answer that for yourself? How would you answer that if you're talking to a teenager? Is cannabis use safe or low risk for teens? How does cannabis risk compare to other substances? The question here is how we message around the data that we have in relation to cannabis. And it's super challenging because with cannabis, we've got this problem. It's both highly common and highly variable in terms of outcomes. And whenever you have an exposure which is common and variable, then the messaging falls apart. So other things that are common and variable include COVID, right? We haven't done such a great job in messaging on that. Social media exposure. Everyone's exposed to it, but how do we kind of talk about risk? Instead of kind of getting into the nuance in the data, we often tend to get polarized on this. So what I want to do with this talk is give you a little information that could be helpful and inject some of that nuance back into the conversation. But cannabis doesn't make it easy, okay? It's very challenging to study this. And one of the reasons is because cannabis is actually a combination of over 100 different compounds, most of which none of us care a whit about or know anything about at all. So this is just a few of the items on there. You've got the terpenes, which provide that smell and flavor to some extent. But there's really only two of the compounds that we focus most of our attention on. And that's tetrahydrocannabinol, okay, which is the active ingredient in cannabis, the thing that makes folks feel high, the thing that we regulate, right? And then the other one is cannabidiol. And this is a little bit different. This is not something that makes us high, but it is something that a lot of people have the sense can make you better from what ails you, regardless of what it is that ails you, okay? And a lot of the medicinal marijuana conversation is around cannabidiol. Okay, another thing that makes it really complicated when you want to talk about cannabis is it's not what it once was. When we used to talk about cannabis, we'd be talking about just this type of cannabis, right? Not so much anymore. We've got cannabis that you can vape. We've got body lotions. We've got gels. We've got edibles. We've got things that you can dab. We've got beverages. We've got candy. When I was leaving Vermont and stopped off at the coffee shop, I could have gotten some CBD in my coffee beverage if I wanted it. I did not, okay? But this makes it super difficult to kind of study this and to be able to measure exposure, because across these different ways that it's administered, there's different levels of the things that we're interested in terms of the THC and also in terms of the cannabidiol as well. And these are just kind of some of the examples of how variable this is. It's also important to note that cannabis today is not your parents' cannabis. It has much higher level of THC in it than it did when some of us were growing up and our parents were growing up, okay? So there's also a lot of heterogeneity in terms of how we respond to this legally. I don't know if this is the latest information, but you can see there's more green than non-green in terms of states that have legalized marijuana for either medicinal or for recreational purposes. It's not there yet in North Carolina, but I've heard that it's going to happen because there might be money to be made. There might be taxes, to be applied to this. So I think it was, Tim Kuhn has said it a number of times, we're just doing a big experiment on us, we don't necessarily know what this is going to do, but we're going to kind of do it anyway and see what happens. And so, yeah, the horse is already out of the barn when it comes to this. One of the problems here as well is we have a term called medicinal marijuana, right? And so that by its nature kind of implies that there could be something here which could be therapeutic or helpful for folks. And that may well be the case, but at least right now, we don't really have any evidence to support that for a lot of the things that people think it might be helpful for. There's one condition for which there's an FDA indication for marijuana. Does anybody know what that is? Yes, infantile seizures, right? Okay, so in most of these cases, the scripts that are being written, the use of the medicinal marijuana is not necessarily for infantile seizures, but for any number of other different conditions as well, okay? And this is having an effect. These are the annual prevalence rates for cannabis use for 12th graders, for non-college youth, and for full-time college youth. And you can see this, little distribution where it kind of started out very high back here in the early 80s. Nancy Reagan happened, okay, and we learned about our brain on drugs, and we learned really well that this wasn't a good idea. And then about actually 1990 or so, this changed and it started to kind of come back up a fair bit since then, okay? And we're about at 40% of high school and college students that report use within the last year. So that's 2 out of every 5 that do. So look at that graph for a second. Look at the shape of it. And now we're going to show you one thing that might kind of help explain what's going on with that. This is from the same survey. This is the Monitoring the Future data. And this is 18-year-olds' perception of the risk involved in regular cannabis use. And so you can see it was lower here when the use was higher, okay? It was higher here when the use was lower. And now the perceived risk has gone down as use has increased. These things are very closely tied one to another. And basically, there aren't many folks any longer that feel like this is really, there's a high risk to your health in the use of cannabis. So in terms of our messaging, if we go in that direction saying, hey, it's going to boil your brain, the way that it did in the commercial back in the 80s, it's probably not going to work the way that it did there. Question? Yes.
Is that regular use of all of the forms that you showed us earlier?
The question is about kind of regular use of cannabis, and so it could be interpreted very differently by different students that are talking about this. And right now, vaping is becoming a much more common way that cannabis is ingested, especially by young folks, right? That are getting introduced through vaping, nicotine. So what I'm going to do in this talk is take you on a little bit of a developmental tour of cannabis use over the first 3 decades of life. We're going to talk about the patterns. We're going to talk about the things before the cannabis use that might predict who's going to become cannabis involved. And then we're also going to talk about some of the potential outcomes of this early cannabis use to try to start to kind of understand exactly what the risks are. And in order to do that, I'm going to give you a brief overview of the Great Smoky Mountains Study, which is based on a lot of this work. So some of you, most of you, maybe all of you, are a little bit acquainted with this study that's been going on here in North Carolina for 25 plus years. The Great Smoky Mountains Study started as a community representative study of 1,400 kids from Western North Carolina, and they've been interviewed and followed up now 12 or more times into adulthood about their psychosocial functioning. So when we talk about Western North Carolina, we're talking about the furthest west portion of this, the part that abuts Kentucky and South Carolina, and also the Great Smoky Mountain National Park, from which it gets its name. So one of the interesting things here is it's a mixed urban-rural area, primarily rural out here and very geographically isolated, but it's also an area that gets visited very frequently from folks outside this area. Great Smoky Mountain National Park is the most visited national park in the country, okay? And so a lot of us go out there and we experience the Smokies like this. And that was the way I first experienced the Smokies on a backpacking trip when I was in college. That involved bears and stream crossings and such as well. But there's more to it than just the beautiful mountains. It's a place that, a lot of people live, and you can see the kind of beautiful landscape that you have out there. It's a place that's made up of a lot of small towns that are kind of concentrated in the way that small towns, we think of them as being used to being. And it's also an area that has higher than the national average rates of poverty as well. So this is one of the reasons it was originally chosen. It's a rural area where there's a high rate of child poverty. It's also part of this group right here, which is the counties that make up part of Appalachia. Okay? It's part of this south central part of it right here. And as such, it's kind of afflicted by a lot of the challenges that are faced by the rest of Appalachia. Very high rates of suicide and drug overdoses right now. This has not abated with COVID at all. We've had a couple of GSMS participants that have overdosed within the last 2 or 3 years. So this still continues in Western North Carolina and throughout Appalachia. This is my super busy slide that I'm not sure if I should be including or not, but I like it myself. So there you go. You'll have to put up with it. This kind of tells a little bit of the history of this study, and I'll just kind of walk through some points. But the study started back in 1993, interviewing a representative group of children 9, 11, and 13 in Western North Carolina. And it's continued on through the present. And you can kind of look on the top and see how it's kind of changed funders over time. Started out an NIMH study, became a NIDA study. Later, it was funded by NICHD. And actually, I have to update it because it's been funded by NIA as well right now. You'll notice if you do the math, it started in 1993. We're going to hit 2023 next year. So Smoky is going to turn 30, which is pretty exciting, and it's continued to be funded. Here you can see in the yellow boxes the different assessments and the ages at which assessments have been done with the different cohorts as well. All the way through the late 30s, and then we're data collection in the early 40s right now. So originally there was 1,400 participants. We've completed on average, or the median number of observations per participant is 10. And we have over 12,000 observations on these 1,400 folks from ages 9 all the way up to their early 40s. So it's a really distinctive resource for studying things like this that occur early in the lifespan. Okay. That one, there we go. Not going to kind of go into too much detail here, but it originally started as a psychiatric epidemiological study. So it was very focused on the assessment of mental health. It was focused on the assessment of substance use, the things that we're going to be talking about today. It's also focused on trauma and early adverse experiences in psychosocial functioning. So there's a lot of information about that, and some of it we're going to kind of get to. It's also, we've collected biomeasures along the way, height, weight, pulmonary function. We collected blood spots from day one with 9-year-olds, and a lot of them were willing to provide that. And so we have over 7,000 banked dry blood spots on our participants at this point, which have been assayed for things like pubertal hormones, estradiol and testosterone, stress biomarkers, inflammatory markers, DNA sequences, and then also for methylation markers as well. The data has been linked up with administrative, education, criminal, juvenile justice, voting, and health records. And then we've also done geospatial coding and census data linkage to kind of fill out the picture of these lives. So like any study that goes on for 25 plus years, it started out being about one thing: how many kids in rural America struggle with mental illness and how many of them are getting the help that they need. And it's become a study about many other things that we never anticipated, including about cannabis, which we'll be talking about here right now. So let's start out with the basics. Just how common is cannabis use in the sample across development from birth to age 30? And to be fair, it doesn't really start out at birth, okay? We started out at ages 9, 11, and 13, but we are making a strong assumption that cannabis use was pretty low in those early years. And that seems to be supported with the data here. So I just want to kind of orient you to this very kind of simple prevalence curve that we see here. This looks at any cannabis use reported in the last 3 months from ages 9, 10, all the way up to age 30, okay? And we have it broken out into a number of groups. We have males and females. We also have broken it up into our American Indian and non-American Indian sample as well. There's 350 of the participants from GSMS that are from the Cherokee tribe in Western North Carolina. They do prefer the term American Indian, and we've broken them out in this as well. Couple things to notice: you'll see a very characteristic curve that if you study adolescents and late adolescents, you'll see for a lot of different behaviors. Starts out really low in terms of use. It increases significantly from ages 13 to 16 to 19. It peaks out in late adolescence at 19 and 21, and then it starts to desist, okay? And if I was to show you a similar curve for criminal behavior, for alcohol use, for high-risk sexual behavior, and for a number of other outcomes, we would see a similar type curve. So if you're interested in development and you're interested in a particular risky point in development, I think you can make a pretty strong argument that not just adolescence, but late adolescence in particular should be a time that you should be focused on. And there's a lot of good neurodevelopmental reasons why that is the case. And then on top of this, we often kind of take late adolescents and we take them out of the home environment and we put them with their peers, and that can also have implications as well. But what we see here is that use itself topped off at about 30% for males, and then about half that at about 15 to 18% for females before it started to desist. So this is any cannabis use. So now we're going to kind of progressively get a little bit more stringent. Here we're looking at weekly use in the last 3 months. You can see now we've dropped to a little bit below 20% for males, and let's see, about 5 to 8% for females in terms of health rates. Daily use, now we're down to 10% and maybe 5% for females. And then here's a prevalence of individuals meeting criteria for DSM-5 cannabis use disorder. This is the way that we kind of look at addiction for cannabis. And the rates are actually look pretty similar to what we had seen for the daily use rates as well, at around 10%. So even though we showed that it was 30% in any 3-month period, if you look at a survival curve of having ever used, we can see that it's actually between 70 and 80% of our participants that report any cannabis use by the age of 30. So everyone, or most everyone, has exposure to cannabis. They've either used it themselves or they know someone that's used it. And again, that kind of makes it really difficult to do public health messaging around it. There's a large portion of them that have also reported weekly use, and 30% or so that have reported daily use at some point by the age of 30, okay? This is really this is the most commonly used illicit substance, or formerly illicit substances, as the case may be. So just another point about this overlap between daily cannabis use and cannabis use disorder. The curves look similar, the peaks look similar. It might be reasonable to suggest that we're talking about the same folks here. It turns out that isn't quite the case. This looks at the co-occurrence between daily use and DSM-5 cannabis use disorder. And we can see that, for example, of those that are kind of daily users, a high proportion of them meet criteria for cannabis use disorder. But of those that have cannabis use disorder, there still are some that are not daily users, okay? So there's a lot of overlap, but it also is kind of distinctive. And in our work, when we're thinking about problematic frequent cannabis use, we look at folks that either report daily use or report DSM-5 cannabis use disorder because these are distinct. So let's talk a little bit about risk for early problematic cannabis use. And here it's important to make sure that we're focused on the right thing. We could just kind of say, what are the predictors for any cannabis use? But that's not really what we're interested in. What we're interested in is particular patterns of cannabis use across development. So whereas we see this curve for use, when we actually do group-based longitudinal analysis on this, we see it's actually a mixture of a number of different groups. So we obviously have some folks that are here at the bottom that are kind of low risk. Actually, that's the largest group, that's 76%, which is heartening, right? We also have a group, oh, okay. I didn't realize I had this. What's not working very well though? So maybe there's a good reason. That's actually kind of weird. Okay, let's go back there. So that's our low risk group. We then have a group that's adolescent or late adolescent limited. And this is exactly what the curve shows. Folks that use, and then they kind of come out of that in their 20s and they stop using at that high level. That's 13%. So it's good to see a lot of folks fall in that desistance group. We also have a group that you can't really see here that increases and then also persists in their high level of use. That's obviously one that we're most interested in, and specifically discriminating between adolescent limited and persistent. The goal of what we're trying to do. And then you wouldn't imagine it by looking at this, but there was a group also that was adult-onset, that hadn't used in late adolescence, that did report using at a high level at age 25 and 30. And that's the smallest group, only 4%. Other groups have reported finding that sort of a group as well. Other studies have reported finding that sort of group as well. So now let's talk about risk for these. We're going to take each one of those groups that are the use groups and compare them to the low non-problematic use group in terms of childhood risk factors, mostly before they'd ever been exposed to cannabis, okay? We also have late adolescent risk factors. I'm going to focus for this talk on the childhood risk factors because those are the ones that occurred earliest. And you can see, and this isn't surprising at all, but behavior problems are a strong predictor of folks that get cannabis involved in adolescence. Prior exposure to substances, strong predictor of cannabis involvement. And you'll notice that's kind of a theme. Behavior problems and substance use are going to be predictors for a number of these groups. And then we also had family dysfunction and family instability, some sort of family conditions that maybe kind of set the context where the person didn't have the same level of exposure, of monitoring from their parents, and were able to become cannabis involved. okay? This is kind of our baseline. This is the adolescent-limited risk profile. It's a little bit different for the persistent group that continued to use in adulthood. Here we see, interestingly enough, there actually is an association with conduct problems, but you also see that anxiety and depression in childhood predicts those folks that are going to persist in their cannabis use into adulthood. And what's interesting is that this not only predicts it as compared to the non-problematic group, but anxiety also predicts it as compared to the desistance group as well. So this is really something that discriminates folks that are going to be long-time cannabis users. Again, we see a lot of risk associated with other forms of early substance use, and then also affiliation with bad peers and school expulsion. We were interested in this comparison between the desistance group and the adolescent, or the persistent and the desistant group. So we also looked at different types of cannabis use disorder symptoms that they reported to see if there was differences in their profiles that discriminated between who would persist. And the symptom related to craving best predicted those folks that were going to be persistent users. So those folks that kind of used, when they didn't use, they kind of felt most like they kind of wanted to get back to using. The folks that wake up in the morning and it's one of the first things that they want to do, it says something about how they're kind of physiologically kind of primed for this as well, and potentially kind of emotionally primed for this in other ways. So there does seem to be this discrimination between those two. The delayed cannabis use group looks different. They do have some history of behavior problems, a lot less in terms of substance exposure, but there are these early victimization experiences, which significantly predict those folks that are going to start using when they become adults, but not earlier than that, okay? So this is just kind of a summary of what we've shown. What we found interesting here is that each of the use groups had a distinctive risk profile. And so to that extent, there was some way to tell a little bit about who is going to fall into each of these different groups. So now what we want to do is to kind of go shift gears and to think about the outcomes of this early use. How does this affect functioning in adulthood in a variety of areas, substance use, mental health, and these and in other areas too. And there's so many different ways that folks have studied cannabis involvement within adolescence that we wanted to look and to compare different ways of characterizing adolescent substance use and to see which of these ways of kind of characterizing it best predict long-term outcomes, okay? So some studies have looked at just cannabis use disorder as a predictor of later outcomes. So we had a variable for cumulative cannabis use disorder, the number of ways at which they met criteria for. A lot of folks have looked at frequency measures. So we included a measure for the number of ways at which they reported daily cannabis use as well as an indicator. We included the 4 different developmental groups that we had talked about before. And then we also looked at a variable for those that had used very early in development. Here it was defined as prior to the age of 16, okay? Because there is this hypothesis that getting to it early, brain is still developing, might be most likely to have kind of lasting effects. And so we want to kind of compare these different definitions for what is kind of problematic use. And this is kind of one example of that in relation to having any meeting criteria for any psychiatric disorder in adulthood, which is defined at ages 25 and 30, based upon these earlier use patterns. So we can see the number of times that they met criteria for cannabis use disorder. There is increased risk, and then significantly increased risk in the folks that have met criteria 3 or more times. We can see some increased risk associated with daily use, some increased risk associated with the very early use before 16, and then some differences between our different developmental groups. We have our low no use group here. We have our persistent group here, our adolescent-limited group, and our adult onset. In this case, though, once we accounted for the risk factors that we had looked at previously that predicted who was likely to use cannabis use, none of these associations were significant at all. They were completely attenuated, okay? So this is a case where cannabis use is associated with it, but it seems to be accounted for by earlier risk factors. That makes sense? Okay. And that turned out to be the same story with anxiety disorder status and depressive disorder status as well, where there seemed to be an association, but it really was accounted for by a lot of the early risks that they had experienced, not necessarily by the cannabis exposure itself. Okay. So next we looked at different types of substance use in adulthood. Here there was a strong association for all of our definitions with regular nicotine use. And here, these associations were not attenuated when we accounted for the early risk factors. So there did seem to be some additional effect, independent effect of some of these risk categories, particularly daily use, cannabis use disorder, and then the persistent use on later nicotine use. And this was a pattern that held up for likelihood of having an alcohol diagnosis in adulthood, and also for the use of other illicit drugs, primarily heroin, cocaine, and methamphetamine. So we're not showing that these cannabis definitions are associated with later mental health, but they do seem to be associated with later substance use. And this type of a finding kind of supports that whole gateway hypothesis that we've kind of all heard about, where exposure to kind of one kind of lesser drug might then kind of make you more likely to try a drug which has more adverse effects. But it does it in that way that isn't necessarily all too helpful, because what we see is that most folks that do use illicit drugs have used cannabis previously, but most folks that use cannabis do not transition to use illicit drugs. That makes sense? Okay. So it's a pathway, but a lot of people, don't necessarily follow that path as well. It's a risk factor. Next, we wanted to look more broadly at functioning in adulthood, and we developed these 4 scales to do so. We wanted to look at physical health functioning, at risky criminal behavior in adulthood, at financial functioning in adulthood, and social functioning. So we created these scales from a number of different indicators from our surveys at ages 25 and 30, and looked at them in relation to the different cannabis definitions we had. And here we saw a pretty strong dose-dependent association between the different definitions: cannabis use disorder, daily use, early use as well, and in some of the developmental groups with self-reported health problems at age 25 and 30. When we accounted for some of the risk factors that we looked at before, the things that were most potent were chronic use and recent use. Okay, so the daily use group, the persistent developmental group, and the adult onset group. Okay. Some of the other associations were attenuated. A similar sort of analysis with risky criminal behavior. You can see it looks, again, like there's a very strong association. After accounting for the early risk factors, it really was the chronic and recent use in the daily use group. The CUD group was significant here as well, and then particularly this persistent group. So there does seem to be a number of different definitions that are coming up time and time again. And to a somewhat lesser extent, we saw a similar sort of a pattern with financial functioning in adulthood. This was things like educational attainment, ability to hold down a job, income in adulthood, number of times fired, and so on and so forth. Again, significant associations after accounting for the risk factors primarily related to chronic and recent use. Okay. Social behavior is where we saw the least impact of cannabis use, and these were completely attenuated after accounting for early use. I don't think I'm going to go through the derailments, but suffice it to say, we created an index of adult outcomes that would be considered on the face of it sufficient to suggest that someone had been disrupted in their transition to adulthood. They had to graduate high school. They were put in jail. They had a felony conviction. They maybe had a teen parenthood. They've been fired from multiple jobs. This is our definition of kind of derailments, things that really show a disrupted transition. And here we saw strong associations, particularly with our kind of cumulative use groups, and then also our persistent group. So I think there was kind of useful nuance that kind of came from this comparison of the different definitions of cannabis involvement. So in terms of outcomes, early use was not associated with emotional disorders, but strongly associated with adult substance use. There seemed to be some specificity there in terms of the outcomes. The variable, really early use, was not associated with any of the long-term outcomes after accounting for risk factors. So that hypothesis that it's the folks that kind of get it earliest are going to have the most trouble did not hold up here as compared to the other definitions. Okay. Most potent was the daily, continued over time cannabis use beginning in adolescence, and that seemed to be problematic for the substance outcomes and for the functional outcomes as well. This may not be too surprised. Those that get the largest dose, they're using all the time, and they're using for an extended period of time, are the ones that have the trouble. This might be what we would expect. And then cessation of early use, so our kind of adolescent-limited group, it did not fully eliminate later risk, but it did attenuate a lot of those associations. So having stopped, having had this normal developmental pattern of, oh, it's college or my early 20s, I'm going to use a lot, but now I'm going to kind of maybe get serious and stop, was associated with more kind of limited outcomes later on. So in some ways, that's kind of heartening too. There is kind of a return even after a person has kind of used at a very high level. This is, I don't quite know how this, this kind of fits in as well. It's a little different, but here we were looking at, does this early use affect aging itself? Okay. And, there's not quite as much you can do with this outcome maybe as you can with knowing that someone has substance problems or financial difficulties. But here we were able to estimate a person's biological aging using a set of different epigenetic markers that are associated with age. And it turns out that when you create this methylation age variable and then you associate it with chronological age, there's a very strong correlation, as you see here. And then you can look at this biological or epigenetic age in relation to an exposure and say, is that exposure associated with increased epigenetic age, decreased epigenetic age? Now, in this study, we had the advantage of having multiple biological time points over time, okay? So we were able to look at change in epigenetic age from the end of adolescence into adulthood. And we wanted to see, did using cannabis in adolescence accelerate your epigenetic aging, kind of going into adulthood, or maybe decelerate your epigenetic aging, okay? And we looked at that in relation to alcohol involvement, smoking, and cannabis. And cannabis and alcohol both were associated with accelerated biological aging as measured by these epigenetic markers. When we looked at these simultaneously, the alcohol finding dropped out and cannabis was the only substance that was associated with accelerated aging, which is not necessarily what we would have predicted. I would have probably put money on nicotine myself, but that wasn't, what we saw here. It was associated with cannabis. And this was accounting for the differences in the time point and a number of other variables as well. So this is kind of this suggests that cannabis could actually be involved and can contribute to this kind of biological aging process. So a couple caveats. Of course, because all studies have them, is that, this study has a lot of strengths, that I talked about. It's community representative, it's perspective, there's long-term follow-up and such, but it's also not population representative. There might be ways in which Western North Carolina are different than other parts of the country. Cannabis use was illegal in NC during the study. There's now most of the country where that's not the case. Although even where it is legal, it's still illegal for youth that are kind of in adolescence. So it could be applicable in that way. There's always the potential for unmeasured compounding here. And specifically, you might think of something like genetic risk, that could be associated with the propensity toward cannabis use. There have been some very large GWAS studies of markers associated with cannabis involvement. And there have been a number of markers that have been identified that account for a very small percentage of the variance in later cannabis use. So that wasn't included here. And we want to be careful because of the unmeasured compound about making any sort of causal claims, just because there seems to be an association doesn't necessarily make it so, as you can see over in the side there. Okay, so I wanted to kind of come back and maybe facilitate the discussion around this by our kind of public health questions. What do we say when we're asked from a public health perspective about cannabis risk? What do we say to college students? What do we say to children? What do we say to others? Is it different for teens? And how do we kind of message that? We have the challenge that most teens have had some exposure, that they probably know someone that has used and is doing okay. They might also know someone that's used and maybe used too much and having trouble, but you also have to kind of deal with that sort of anecdotal experience. And, when I give a talk about this to college students, I often get a question, from a student that's kind of trying to be a bit of a smart aleck, and they say, okay, so what's worse? Is it alcohol or marijuana? And I typically have to say, okay, well, probably alcohol, because of the mortality that's kind of associated with alcohol use. So there's also going to be always that comparison that's made with other substances. I think a couple of takeaways that are clear from this is one that, I made this point earlier on, but late adolescence is really kind of that forgotten critical period in development. We focus a lot on adolescence. We focus a lot, kind of earlier in development as well. But there's this interesting combination of risk for a number of different potentially, really negative outcomes that happens in late adolescence. And also this kind of shifting in terms of moving them out of their kind of family home and into independence or to college, which can actually exacerbate that. There are studies that show that you kind of put teenagers, and especially in late adolescence, with other teenagers, and that has effects upon their decision making, and not necessarily in kind of a useful way as well. So this whole idea of sending kids off to college at 18 years old, when their brain is really well suited to some things and not necessarily for other things, has some drawbacks to it. That's an important thing to consider. We were heartened that there's early risk factors that seem to be able to discriminate and tell us a little bit about which individuals are likely to have kind of long-term problems. We talked about anxiety and depression in childhood, also kind of having that experience of craving after one uses cannabis use. And then we do see consequences of cannabis involvement, but it varies. There do seem to be some clues as to who's going to have the most consequences, and not surprisingly, it's folks that use the most for the longest periods of time. Does this mean that kind of using here and there on a weekly basis is going to be okay? It probably depends upon the individual, but there really isn't strong evidence for some of these poor outcomes for those folks, okay? So this is combination of a number of different studies that we've done. So if you want to kind of learn more about it, you can kind of go to the same journal, the Journal of the American Academy of Child and Adolescent Psychiatry, and read all about it. And obviously, study going on as long as it has required a pretty impressive team. Jane Costello and Adrian Engold were the original PIs of the study, and led the study up until a few years ago before they decided to retire to their rural estate. And Lily Shanahan, Sharika Hill contributed specifically to this work as well. NIH has begrudgingly been generous, and our participants amazingly, continue to come back to talk about a lot of things in their life that are going well and maybe some things that aren't going well. Their parents. And then what really makes this study happen for 25 plus years is having that field staff, and Wanda Burns and Rebecca Woodward have been kind of the pillars of that and kind of kept it as strong as it's been. So with that, I'll stop talking and take some questions. So should I call out people, or how does this work? Sure.
I just wondered if you say, it's always interesting to think about when the use of substance, whether abstinence is trouble. Right. Some of the hardcore substances you might say, yes, we would never use, but marijuana doesn't seem to me to fall in that category the same way alcohol does. In fact, we want people to become mature users who know when and how to use it responsibly. You see a story for marijuana that fits that.
Yeah, I think that there probably is if it's targeted to the right group. So, when I lived down in Durham, I shared some backyard space with a faculty member at a prominent university who would go out on his back deck and often smoke on a Friday night or a Saturday night, some marijuana, and, we would kind of, talk shop and such, and highly functional in a lot of ways. I think maybe within kind of groups that have fully developed brains, that would kind of seem to be really important. There might be kind of, I don't even know if it's quite a harm reduction, but there might be space for kind of responsible, moderate use in the same way that people have that conversation around alcohol. It gets a lot more tricky to have that conversation with teenagers, before you kind of know how they're particularly going to respond to this exposure. Still is the case with even hard drugs like heroin, that it's only about a third or so of folks that use it that kind of get hooked, on it in that very strong way. It's obviously lower than that for marijuana. So there's a whole lot of variability, but it is kind of, you're not quite sure, who's going to respond which way in a very precise way just yet. These provide some clues, but there's no precision medicine here.
I've been thinking of children, childhood alcoholics, so having exposure to substances, specifically alcohol, makes children more likely to also end up developing alcohol use disorder. Is there something like that in terms of cannabis? Study, like maybe a parent having some substance use disorder would be related maybe to earlier onset or.
Right. So that was one of the indicators. We had kind of a family dysfunction variable that you saw that was related to the adolescent-limited group in particular. Part of that was parental involvement in substances. And you have to go back a ways there too, because some of the parents haven't been involved recently, but they had, kind of prior to becoming parents. And there is kind of that strong association. I've seen other studies that have kind of done that, and that tends to be one of the strongest kind of predictors is, do you have a parent that's kind of had problems with this in terms of your continued use? So I think that's an important story. There is something kind of familial about this, and that could kind of speak to that genetic link or to other sorts of factors as well.
If I can piggyback off of that question, you have assessments of substances, but imagine when there's disorders, you might have cases where there's older siblings using younger siblings. So curious if there's assessments of that.
Yeah, we don't have sibling data in particular. We do have information as to whether or not they're kind of associated with peers that are kind of introducing them to this as well. And there's a whole literature around who's most likely to be initiated early to substance use. We're just having a conversation this morning, it feels like, about pubertal timing. as being one of those variables, with some folks kind of developing earlier and then having an older peer group and being introduced to these things, which, is really the way a lot of this happens, is folks kind of developing kind of a social milieu where these are introduced. That can happen through siblings. It can kind of happen with peers as well. Yeah.
There's also a question in the chat.
Okay.
Why is the group categorization Indian versus non-Indian? Maybe the question maybe leads to why were other categories.
Yeah, so the reason why that is because in this Western North Carolina sample, those are the only groups that are kind of large enough to compare. We oversampled for the Cherokee participants, so there's large enough to kind of compare them to the non-Cherokee. Now you saw that the profiles weren't all too different. I think that they peaked a little bit higher for some of the Cherokee males, and they started a little bit early for the Cherokee females. But there weren't any differences in terms of actual kind of risk factors across the Indian versus non-Indian comparisons.
But it did seem like the adult-onset group was predominantly right. It was that one. I don't know if that's perceptual. I know this is a very wide error bar, so it's a small group.
4%, Yes. So this is the one where, when it comes out of kind of the group model, you then kind of go and you make sure that in the literature there's precedent, for this as well. And it does seem like there was enough other studies that have kind of reported this. And we were wondering about this as, being a primarily kind of female group that might have been involved in kind of early family parenting. They might be kind of young parents, which kind of kept them out of the late adolescence substance use game to the same level. And so now they're kind of, later on, kind of in adulthood, their kids are growing up a little bit. There's a little bit more kind of freedom there. And that's where we kind of see the substance use kick in. So there's some story around that, but it is kind of a smaller group to work with, right? Yeah. Okay.
It seems like not very significantly at the time. And then it also seems like and you're more socially like those maybe make brownies.
Right. Right. Yeah. No. Well, and so one of the advantages of this data being a little bit dated is that there was less of that variability in terms of our assessments and when this was created and when this was originally collected. But it's become more of a challenge with recent data waves, right? Because are we going to be kind of coding a similar way, someone that's having an edible or having a little CBD that they're kind of rubbing into their kind of leg for some sort of pain, or they're kind of using something for the nausea that they're experiencing related to a chronic health condition? It's much more difficult, I think, to kind of assess this at this point in time. Some folks might not even necessarily know, kind of what they're assessing. And then on top of that, there's kind of synthetic, marijuana as well, which isn't necessarily marijuana at all, but they may think of it as being such. So all these things mean you have to ask questions in the right way and be sure that they understand exactly what you're asking about. I think blanket questions about cannabis use kind of might start to miss out, especially because there's actually a wellness culture around cannabidiol, and it's considered to be really useful for a lot of things. It's also, there is some evidence that it can kind of be helpful for, folks that are kind of smoking in terms of, getting the right kind of high. That's not something that's going to be kind of problematic. But I don't think you'd quite want to categorize someone using cannabidiol every day the same way that you would someone that's kind of smoking up, so. Other questions? I had a slide here. if you're interested on kind of a review from the medicinal marijuana literature. So this is the review that I wasn't involved with. But there really isn't strong evidence to support the term medicinal marijuana. And there is possible that there could be studies that kind of change this, but the data isn't there right now. I do a survey with my college students to ask, hey, does marijuana help with anxiety? A certain amount of folks think it helps with anxiety. There's really no evidence of that. There's some evidence that for some people it might actually exacerbate that. But some folks believe it, same thing about ADHD and other things as well. But it really kind of weak across the board in terms of its medicinal effects. Any other questions from the chat there?
Not yet. You have one, actually.
Sure.
So we're kind of working on a study with the race data on indication of substance use, and we're talking about and looking at which substances may be coming before others in that sample. And you mentioned how cannabis seems to be great. So do you know if it was like if it tended to be the first one to be used, then followed by others or not?
And I want to be careful about overgeneralizing, but if there is kind of a pathway that we commonly see, it's nicotine to marijuana, there's a lot of evidence for there being something that comes before marijuana. It's not kind of the first thing, but it can be kind of that linked in some cases to other illicit substances, perhaps more so than alcohol alone or nicotine alone. But typically we find it follows, nicotine use, and it can do that because it's delivered the same way. They could be smoking, nicotine, move on to marijuana, and you can also start out vaping. And then someone says, hey, I got something for you to vape that you might want to try, and nobody knows that it's not nicotine, and so there you go. It's more and more common that people report vaping both. Yeah.
I guess it's just follow-up, but I think that cigarette use tends to be common, like lower SES, like when that is that kind of okay. And would that, I'm probably making I call them something here, but would then it be possible to expect that in marijuana would be more common in populations that are at higher risk for actually smoke? Does that make sense? Because I'm wondering, like, if this is like also like they are pretty isolated, there might be a lower income population compared to like the North Carolina average or the country average.
Yeah.
So I wonder why substance use may be even higher in this population versus or cannabis use higher in this and others due to other like.
I think you're going to find that there's an association there, which is probably accounted for by some other, variables as well above and beyond kind of the SES. I'm in the college setting, and you could kind of see the data back there for kind of college versus non-college, and they're remarkably similar. And there's a amazing stratification that we have SES wise when it comes to kind of college attendance. And so it's interesting to see there that it is still happening with the college students. I certainly see a very kind of high level of it too. So I think marijuana probably, as much as some other substances, doesn't discriminate as much kind of along SES lines. I don't think you're going to kind of find a whole lot of stratification there. Yeah. They are right now running probably one of the largest experiments in the country about effects of marijuana on your brain. Now, if you're acquainted with the ABCD study, 10,000 kids that we're going to be imaging every year. The imaging core for that is up at Vermont, so we kind of hear a lot about it. And they have some of the early findings for cannabis exposure at like 14 years old, and then kind of the imaging findings. And they're not seeing a whole lot of strong associations just yet for that kind of early use. It's going to be more interesting when you kind of, look at that on kind of, brain function at 18 or 19 years old. There are some studies from Europe, the Imogen study in particular, that show maybe some association with some frontal cortical thinning, which, we want our cortices to thin a little bit in adolescence. That's part of the job, is to get pruned, but overly being pruned for folks that are exposed to marijuana. But it'll be really interesting to see, finally answer Nancy Reagan's question about what does happen to your brain on drugs. So stay tuned for that. We good?
Thank you.
Okay, thank you very much.
All of our members.